recording also. So welcome today to the Consortium of Gender Scholars, our Gen Con virtual talks. It's really a pleasure to be here today with you all. So today, to give you a snapshot of what will be coming. So we're delighted to have Antonio Sarria Santamera with us, talking about endometriosis, a clinical challenge with a significant impact on women's life. And before we get into that, just want to give you a bit of an overview of Gen Con. So for those maybe who haven't been to a talk before, either in person or virtually, so Gen Con focuses on bringing together and supporting gender scholars in Kazakhstan and those who study in the Central Asian context. Gen Con's primary purpose is to generate research designed to make meaningful change in various areas of society with regard to gender equality and the advancement of women. Gen Con is interdisciplinary and based at Nazarbayev University. So what does Gen Con do? So in particular, we hold research talks and forums. We connect gender scholars. We conduct funded and unfunded research studies. We publish scholarship for local and international audiences. We develop partnerships locally and internationally. We provide mentoring and expert consultation. And ultimately, we empower the scholarly community. For today, in particular, we would like to thank our organizing committee members, including Almira Tabayeva, Arai Daniyozova, Douglas Cohen-Miller, Kelly Grace, and Jana Ijakenova. So I thought I'd stop screen sharing for a moment, and we could just have some brief introduction. So this is where, when we were face to face, we would do this also, but over coffee and tea and coffee and snacks. And this is just a chance to say, okay, who are you and why did you come here today? Maybe there's a particular reason. And so I'm going to just kind of go around, and as I see people's names, then maybe you can unmute and come in. So actually, I see Gulmira first. Would you like to come in?
Yeah, sure. Hello, everybody. Thank you, Anna, and nice seeing everyone. Basically, I'm now in Almaty, in my hometown. I graduated last year from the Graduate School of Education, and currently I'm teaching academic English at QMEP University. And I am here to listen to this fascinating, important topic because it specifically has to do a lot with us. And yeah, I'm just very curious, and thank you for this.
Great. Thanks so much, Gulmira. Glad you're here. Liza, would you like to come in?
Thank you, Anna. Hello, everyone. Thank you for making this research talk so we could learn more, hear more. My name is Elizaveta Kamilova. I'm from the library, and I was writing today about that previously I already have done and partnering with Gen Con and with Anna especially to do some projects together, to perform some interesting events. So I'm glad to be with Gen Con all the time because it's really interesting and important thing to happen. And thank you for performing this.
Thank you so much, Liza. Really glad you're here. Asim, would you like to come in?
Sure. Hello, everyone. Thank you so much. I read this advertisement in my mail. I'm research assistant in SSH, School of Science and Humanities, and I'm interested in mainly in just to be sure, and I want to learn more. So I try to connect, try to stay in touch, and see this kind of lecture. Thank you so much.
Great. Thanks for being here, SM. Dana, would you like to come in?
Yes. Good morning, good afternoon, everyone. My name is Jana. So I'm part of Gen Con, and I'm so glad to see Professor Antonio. And I think he's the first one from School of Medicine to present at Gen Con. So I'm glad that you are breaking the ice, and I'm looking forward to see more people from the School of Medicine. Yes, and I'm looking forward to this presentation, and yes, hopefully more people will see the recording, and the School of Medicine will be engaged in our GenCon as well. Thank you.
Thank you, Jana. What about Murray? I'm saying that correct. Saitova?
Yes. I'm not a medical student or related to anything in medicine. I'm just living with this condition, so I'm interested in this talk. Yes, my husband forwarded this email to me, so thank you.
Great. Thank you so much. Really glad you're here. What about Banor? Would you like to come in?
Hello, my name is Bilnur. I am a PhD student at School of Engineering. I'm also working on biomedical sciences, so it's quite interesting topic that caught my attention. So I decided to participate in this lecture.
Great.
Oh, thank you very much.
Glad you joined us, Banor. Let's see, Alina, would you like to come in?
Good afternoon, everyone. I'm a ZIP student, and I decided to visit that because I want to learn more about this thing. Thank you.
Great. Thanks for being here. What about Kelly? Would you like to come in?
Hi, I'm Kelly Grace. I'm new here at NU and in Kazakhstan. I've been here about a month. I am a teaching fellow in the Center for Preparatory Studies and part of the leadership team. So I'm excited to be here. I do primarily work in gender and education.
We're glad you're here. Even before Kelly joined us physically in Kazakhstan, that we have pulled her into Gen Con, and so really appreciate your work. So thank you. And let's see, Igarim, would you like to come in?
Hi everyone. Sorry, I turned off my video. So nice to be here. I'm a music student, as Alina said before. I'd like to find out something interesting in this field. However, my major is in biology. Yeah, right. My bachelor degree is in biology, and I will study to get the master degree in education. So I love like learning something new. Thank you.
That's great. Thanks, Igarim. Yeah, we're happy to have people across disciplines, right? This is where gender affects us all, right? Doesn't matter what discipline we're in. Dana, would you like to come in?
Good afternoon.
Hello.
Hello. Do you hear me? So I'm sorry. I'm just currently in the hospital. I'm a first-year resident resident in a family medicine program. I am just interested in. I found it interesting the topic of this discussion. So I'm looking forward to learn something new.
Great. Thank you, Dana. Glad that you joined us. Ludmila, would you like to come in?
Hello.
Hi.
Do you hear me? Yeah, hello,
Sounds good.
Anna. It's really nice to hear you. Yeah, but I'm out, so I can't, turn on my video. But I just saw this email, in NU mails. So, and I've heard about this disease. I guess it's, some people, they think it's not very serious, but so I think that we need to heal it and so on. So I just would like to learn more about it. Yeah, so actually I'm a research assistant, and so that's why I also try to, stick to a new community. So nice to see you all.
Great. So glad you joined us, Ludmila, former student of mine. So happy to have you here. Okay.
Okay,
great. I'm so happy to have you all here. So great to learn more about you. It helps us, see what this community is, and this is the part of the community development. So now we can just a little bit of general housekeeping. So recordings, the video will be shared on social media. We have YouTube and Facebook, LinkedIn, and Instagram. PowerPoints will can be made available, or will be. So thank you, Antonio, that you're happy to share your PowerPoint, and that will be at the NU repository. And so now I'm going to go ahead and pass off to Kelly.
Thank you. So we're really excited to have Dr. Antonio Sarria Santamera here. And he is a physician dedicated to improving population health through the understanding of what works in medicine and developing high-performing health delivery systems. His research focuses primarily on providing science-based insights to strengthen healthcare systems, improve quality performance, with a particular interest in non-communicable conditions, NCDs, because of the impact that those conditions pose to patients, health systems, and society at large. Antonio has contributed to expand our knowledge regarding how we approach the management of those conditions, looking at the ways to make healthcare better, including the use of information and communication technologies, as well as using population-based data platforms for improving patient care, with a special emphasis in strengthening primary care. He has published widely in this field and has led several national and EU projects. To highlight the EU Prime Care project, whose objectives were to assess quality and costs of primary care systems across Europe, and CHRODIS+. And an EU project aimed to tackle NCD through the implementation of innovative practices and policies across Europe. His work in the area of implementation is based on the principle that for sustainable quality improvement, it is essential to understand the influence of the local organizational culture, which determines how individuals learn, interconnect, self-organize, and co-evolve with their environment, usually in a non-linear and dynamic way. Also, a little bit of extra info is Antonio graduated from Universidad de Zaragoza, Faculty of Medicine in Spain, where he received his PhD and obtained his specialization in public health medicine from Hospital La Paz in Madrid, Spain. He was a Fulbright Fellow at the Department of Community and Family Medicine at Dartmouth Medical School. He has also been a visiting scholar at Duke Clinical Health Policy Research. He has had clinical and health policy positions in Spain. And before joining Nazarbayev University, he was a senior scientist at Instituto de Salud Carlos III. Third, yeah, sorry, I do not speak Spanish. So where he was the director of health technology assessment for 10 years, as well as associate professor at Universidad de Alcalá, Faculty of Medicine. He has mentored many doctoral master's level students, medical residents, and students. And Dr. Sarria Santamera is a member of EUPHA sections on chronic diseases and health services research, and of ISPOR. Whew, that's a lot of really good stuff.
Okay. Okay. Thank you for the invitation to be, to be with all of you to discuss this disease, this endometriosis, which has been part of my professional life for a few years. So I'm going to be talking basically in my as a health services researcher, which is a peculiar area of biomedical and health research, which is somehow in between clinical research and public health research. And so I'm not going to be discussing the disease, how to treat the disease, but we will have to understand what are the biological characteristics of this problem to really understand what are the problems associated with the clinical management of this disease, because the specific peculiarities of the disease, which is not that really a malignancy, but has certain elements that tremendously affect the well-being quality of life of women suffering from this disease. Of course, I'm not going to be talking of having suffered the disease, and I don't know personally anybody who has suffered from endometriosis. I have seen women with endometriosis, but again, from the other side of the desk, so from the clinical side. But I have not suffered or know personally anybody from who has suffered from endometriosis, and everything I will explain is from what I have basically researched, which in this specific condition is what we epidemiologists call biased because of the specific characteristics of the disease, because we just see partially what the problem is, and we can only, based on what we call data and what we call evidence, could use then to do this strengthening healthcare systems that previously Kelly was explaining. That is my main purpose. So it's an interesting, but at the same time, challenging health problem to investigate. Basically, endometriosis is the presence.
Sorry to interrupt, Antonio. Did you want to share your screen?
Oh, yeah.
Okay.
No. Yeah, sure. That's my screen. Sorry. I'm new at Zoom, you know. Okay, my screen. Oh my goodness. So.
Perfect.
Yeah. So. Okay. Again, it's not a malignancy, so you are not going to die of endometriosis, but it's going to be with you for a lot of years, and it can make your life pretty miserable. That's a problem. So, but from the clinical side, the problem is that we know what endometriosis is because we can see endometriosis when we basically through laparoscopy or open surgery, but we don't know exactly how this presence of endometrial tissue goes to other parts of the woman's body. So we don't really know exactly what's the origin of this disease. We don't know what we call the physiopathology, which is the process that leads to the cells that somehow circulate and just get to what other organs and then bind there and start to grow. A tissue that, of course, you are totally endometrial tissue is estrogen influence periodically goes through changes, and those changes continue to occur in the other organs where those implants exist, with all the problems associated with those implants. And together, there's also some inflammation reaction, which has both local but also systemic implications. So in any case, this is what endometriosis is, but we don't know exactly how this process really occurs. So at the same time, there's a significant problem to really diagnose endometriosis. Basically, the only way to really diagnose endometriosis is the only accepted gold standard to diagnose endometriosis is through a biopsy. That means that usually through laparoscopy, we have to obtain a sample, has to be sent to the laboratory, and then the pathologist there will tell you if this is endometriosis. That's a problem because that will occur just on a fraction of women suffering from signs and symptoms of this disease. Not all women will get to a situation where a laparoscopy could be considered necessary. So that means that there's a quite variable a not well-defined situation in which women start to have pain, which is the critical problem in endometriosis, to the moment where they finally get, call it the label of official label that you have endometriosis. So one of the problems that typically women claim is that there's a delay in this process. There's a delay in this process. And I can understand that from the perspective of women, there's a delay, but the problem for me is a delay has certain, say, normative concepts. So delay means that there's a moment where the disease could be diagnosed and this is delay. Because the other problem, which is always very difficult to differentiate, is that in this process, since women start to suffering from the initial symptoms of the disease to the moment where presumptive clinical and operational diagnosis is reached, sometimes is relatively complex. Because at the same time, symptoms of the disease don't move, say, constantly. So they are up and downs, not just monthly, but in some periods of time, women may be suffering a lot from pain. The pain may basically disappear. It may reappear later on. And it's relatively complex to really clinically manage a woman with this disease. So the significant impact is basically related with pain. Pain is the main problem of endometriosis. And around pain, we see the significant impact in well-being, the losses in quality of life, how it is pain and lack of energy, which is associated with endometriosis, is also related with a significant impact in women's life, in all dimensions of women's life, affecting their not just physical health, but also their mental health. Depression, anxiety are quite frequent in women with endometriosis, which altogether bring to what we in health economics call the direct cost to the medical care system, because women have a high use of healthcare services, much higher than comparable women that do not have endometriosis. But at the same time, women have a significant indirect cost, and indirect costs are associated with all the losses that in social life, including, of course, work productivity, but it also including the leisure time, the family time, the sexual time, that it's always very complex and very difficult to estimate, but that represents a significant amount also in terms of the overall cost that for the society are represented by endometriosis. So more and more, the approach to deal with endometriosis is clearly individualizes as much as possible the treatment, because basically, as we don't really know what this disease is, we don't really have what we clinicians call the etiological treatment, which is the disease that, the treatment that really kills the disease. What we have is painkillers from different scales that could help to control the main problem, which is pain. We also use hormonal treatments. Oral contraceptives are quite frequently have to be used because the estrogen effect they have. There are new and more advanced hormonal treatment that can be used. And the final treatment that is at the same time, in most occasions, the diagnostic real moment, but also in only some of the women, the final situation is surgery. In surgery, it's really difficult to indicate how much surgery you will require, because the other problem is that we don't know exactly how extended and how deep endometriosis is unless we have this direct observation through laparoscopy. So, and basically probably no more than 60% of women with endometriosis finally get to a surgical treatment. So in this process, what appears to be critical is to establish this individual approach in which elements related with the specific progression of the disease in individual women, as well as their individual preferences in terms, for instance, of willing to get pregnant or not, because if we are using oral contraceptives, we know that we are not permitting to women to get pregnant. Some women will decide that they could not willing to take oral contraceptives because whatever reason. So this is very important, and this is also critical to establish, and that's at the same time the two main points I'm including here in my slide. So this individualizing as much as possible, so personalizing care as much as possible based on individual patients' values, beliefs, and preferences, but also create in patients the capacity of controlling the disease as much as possible. So in this sense, trying to promote in this case women, the capacity to understand the disease, to understand that this is a long process, that probably they are going to live with this situation for a long period of time, and that it's important that they are capable to establish their own specific ways to deal with disease, including, and this is critical and very important, all the psychological and emotional dimensions of the disease. So basically, this is what I say. We have endometrium. This is this cyclical tissue, and then we have when the cells get into the whatever other organ, inflammatory response, and this inflammatory response have both a local component, but also as a significant systemic component. And that's very interesting, and I will talk later, because endometriosis is also associated with other diseases, but also is not associated with other diseases. So we are in the last few years, the idea of thinking in diseases as cluster of families of problems that may be somehow phenotypically at least associated, because they may have also probably certain genetic common characteristics. It's becoming common, and I will later explain you something that we are advancing in this direction. Basically, this is what I previously was explaining. What endometriosis is the presence of endometrial tissue, glands, and stroma outside the uterus, that these implants actually have been seen in all parts of the woman's body. That the main problem is pain associated with other painful situations, something related with menstruation, sometimes related with sexual intercourse, also in occasion related with urination of defecation. So but at the same time, it's quite variable. It's quite variable across women, but also quite variable in the same woman. And there's also certain, and again, not really clear relationship between certain cancers, mainly ovarian cancer, and also an issue of infertility. The issue of infertility is part of endometriosis, partly because endometriosis may affect critical organs in infertility as the ovarian, but at the same time, probably because of the systemic effect that may be in the origin and also associated with the progression of the disease. So theories about endometriosis are 1 + 1 I mean, this one, which is the retrograde menstrual flux, which leads to implants together with lack of our immune system to recognize and, so to say, destroy immediately these implants without becoming full endometriomas, together with another idea that has been proposed, which is that there are probably certain genetic traits that facilitate that in certain families, because in certain families they have been seen an increased risk of endometriosis, plus the other, which is that there may be also certain environmental exposure, because we know that estrogens overall are very much affected by our environmental exposure, and they may be also influencing, either predisposing or enabling that those implants really survive. I said there are everything, all locations really, they have been even found in the brain, in the lungs. So it's really not really clear exactly how this can occur. Again, the main symptom is pain, together with a sense of tiredness and lack of energy. In pain, typically abdominal pain, but again, with very different prescriptions, very different characteristics associated with sexual intercourse. This is, if it occurs, is relatively indicating a problem of endometriosis, but if it doesn't occur, you cannot exclude this. Physical examination it's not really helping a lot. And very important, very important that there's no laboratory test that could either confirm or exclude. No laboratory test can be done in endometriosis, but also image, usually certain type of ultrasounds or MRAs could be indicated. If you see an image could be compatible with endometriosis, it can be, it suggests that this woman has endometriosis, but if you don't find that, you don't really can exclude endometriosis because you don't find, because the description of symptoms, because the physical examination, or because the image don't really point to endometriosis, you cannot really exclude that this woman may have finally endometriosis. So that brings to what I already said, that the diagnosis, the gold standard, and what is actually accepted as a diagnosis of endometriosis basically is the biopsy. But at the same time, we know that this definite diagnosis will occur just on a fraction of women with endometriosis. So in this process, you have to elaborate clinical strategies to really identify women who come to your clinic referring pain, abdominal pain, or the symptoms, that you may suggest a diagnostic test and you don't find anything, and you still, after even the physical examination, consider this woman has endometriosis. And then you go to a point, you say, we have to start treating endometriosis based, again, on what you say, in this personalized process of care, in which you may use or not oral contraceptives or the other more advanced hormonal treatments today available. Again, as we said with a clinical diagnosis, the problem, if you start treating the woman and the woman does not properly respond, you cannot exclude that this woman does not have endometriosis. So, because some women respond to treatment, other women don't respond to treatment. So it's again, so I in this sense, in going back to this concept of delay in diagnosis, and not because I'm trying to defend like clinical colleagues that really are treating or trying to diagnose this woman, is that this is a serious, difficult problem to resolve, and that creates a problem when we try to identify who has endometriosis. There's another problem is that having several classifications of endometriosis, but this basically classification of endometriosis basically requires the direct examination in laparoscopy. So it's not really useful, this classification, unless you bring the woman to the operating room and you see inside the woman what's actually going on. So it's not really helpful, this classification for the initial clinical management of women. And also what is very important is that it's not at all, and that's also clearly identified. There's no association at all between how advanced and how extended or how deep endometriosis is with clinical symptoms. So in this sense, you may have really extended endometriosis, quite deep, and probably your symptoms may be not so are not so concerned with symptoms, but you may have significant pain, significant effect on your quality of life, well-being, and so on, without really having a stage 4 severe endometriosis. So that has brought the idea to try to phenotype these diseases. I bring this because it's an idea to try to classify women based on the progress of symptoms, but more, this is a very good exercise, but it's really retrospective. It's not really a study that puts women in a, say, if I find woman in phenotype A, I could expect this to occur in this woman. It's more, we have this so many women, and based on this so many women, we characterize them in these 4 phenotypes. So now let me change somehow the direction of this presentation. And this is a meta-analysis we conducted, published last year. A meta-analysis, you know, is a study that collects studies and create this, what epidemiologists we call funnel plots, which are all the studies together. And we pulled all studies together, and we create and produce something which is a pooled estimate that indicates what is the pooled estimate of the problem you are considering. In this study, we were interested to explore the prevalence and incidence of the disease. Prevalence is the number of cases that we have of disease in a population, and incidence is the new cases that we have of disease in a certain population. So what we did here is a meta-analysis in which we included all studies that have been published that either were reporting prevalence or incidence of the disease. And this is the prevalence and incidence estimates that we found, which is ranging the prevalence from, say, 1% to basically 5–6%, depending on the type of information that you are using. So what's interesting here is that what we call integrated information systems basically are studies that have go to basic primary care networks that have a defined population, and the studies have extracted all the cases of women with a diagnosis of endometriosis in this population network of basically primary care centers, which may be more or less integrated with certain hospitals. So this includes a defined population. And here, in this defined population, the prevalence is 1%. the other designs, it's difficult to determine, but then we also have the other studies, which are self-reported population studies. What means self-reported population studies? Those are studies which are conducted basically through surveys in population samples, in which investigators just contact persons through different mechanisms, and then ask women, have you been diagnosed of endometriosis? And then we found a prevalence of 5%. So what we have here is this, this is our interpretation. So the problem is that we have here included basically the situation where hospital discharges and integrated information and core studies are basically similar. So what we have here is a situation in which doctors in the clinics indicate that women have endometriosis only at a certain moment in time. They may start treating women with endometriosis. They may start trying to eliminate pain. They may even indicate oral contraceptives or other hormonal treatment, that they may be reluctant to finally decide that this woman has really endometriosis. While if we ask the woman, they may say, oh no, I have already endometriosis because my doctor has already been prescribing me these medicines, because I already have been taking this medicine, because I have been already referred to an obstetrician to investigate whether I have or not this disease. So this is one of the problems, that we don't know who has endometriosis, but at the same time, the consequence is that we don't really know how many women have endometriosis. Okay, this study has specific relevance. We did not this study just because we were only exclusively interested in the epidemiology of endometriosis. It's that because we started this research in endometriosis because back when I was in Spain, we were approached by the Minister of Health, and the Ministry of Health wanted to develop and improve the care for women with endometriosis. And there was one first interest to know how many women have endometriosis in Spain. And there's a lack of consensus of really how many women may have the disease, because that's important for public health definition of what the problem is and the real magnitude of the problem. So, as I said, I may assume that the prevalence of endometriosis is much higher than what we found in the published literature. But at the same time, what is in the published literature is what it is. So, and I cannot say, if you go typically to internet, even if you go to WHO endometriosis pages, WHO will say that 10% of women have endometriosis. 10% of women have endometriosis. In half a time, I will tell you the story of why, how WHO came to this 10%. But this is really peculiar and interesting. But the reality is that probably the incidence of diagnosed endometriosis is much lower. The prevalence of real endometriosis probably is much higher. But in any case, it's difficult to really know exactly what is the amount of endometriosis that we have in a population. So now, briefly, some of what we are actually doing with data from an integrated database that we have access in Spain, and we have data from an integrated network of primary care centers, including 612,000 women. And in this woman, what we found is a prevalence of 0.8%, which is, interestingly, very similar to what, if you remember previous studies, that is this integrated, is in line of what international studies using this type of information have actually used. What is also very important is that you see here in this light and darker blue, the distribution of the population of women without and with endometriosis. And this is very important because endometriosis, of course, obviously, is actually affecting women when they are supposed to be more socially productive. That's one of the main points in terms of what I call as the indirect cost associated with this disease. But we also are doing, and again, this is a very preliminary data that we are analyzing the patterns of diagnosis of the endometriosis in this large database. And we have women from different national origin, from different income levels, from different populations, I mean, sites of urban or rural environments, or whether they are active, unemployed, retired, or what in the database is called non-active, probably are women who are staying at home. So it's very interesting if you just see here there's no explanation, and there's not ethnic or racial evidence of a difference in incidence, but there may be also certain differences in how Spanish medical doctors in primary care are approaching diagnosing women with this type of symptoms, whether they are coming from Africa, Latin America, Eastern Mediterranean regions, or other countries, from other European countries, or because of the income level, or because of the sites of residence. So this is what we epidemiologists call the odds ratio. And you see that if you live in smaller and rural areas, you have a lower probability of being diagnosed of endometriosis, which probably indicates certain differences on how doctors are treating women or considering women coming from showing the same symptoms, depending whether they are in urban, rural, or the national origin of women. So this is what I'm showing here. It's a very long list that probably for clinicians makes sense. Of course, it does for us. It's very interesting, but it's what I told you that endometriosis is associated with some diseases, but at the same time, it's not associated with other diseases. So, and when we have such a large database, it's very interesting that we are seeing that endometriosis is, of course, associated with other, I mean, gynecological issues, with certain digestive issues, with a lot of mental health problems, and with other, I mean, not so clear problems, but it's less associated with other problems like certain, this is also peculiar, elements related with immune situations, with certain endocrine metabolic factors. It's much less, the frequency of dyslipidemia, so diabetes, is less frequent in this woman, as well as the frequent of other rheumatic diseases, osteomuscular conditions, which is interesting to research, because there may be this systemic inflammatory response that may be predisposing or facilitating the implants in women. So as part of this study that we conducted for the Spanish government, we did also a cost of endometriosis study in Spain. Well, it's it's easy to find what you say direct costs, which are the direct medical costs, but it's very, very difficult to estimate absentees, presentees, or losses in other social activities. And again, it just finalizing here, the main issue is pain, and not just because we're talking about pain, but pain is probably, and overall, not just in endometriosis, but in any other disease, one of the most significant burden that our societies have. So pain is a terrible and tremendous impact in terms of direct costs, but also in terms of indirect costs. We are also investigating specifically pain, not just in endometriosis, but specifically as an individual problem, and that pain is tremendous. In the case of endometriosis, pain is also, again, associated with these other signs and symptoms in this woman's situation. And basically, it seems to me, and again, this is my interpretation, that an overall pain is not well treated, not just in women with endometriosis, but in all types of patients. Pain is not well treated. And if you don't treat pain correctly and immediately as it appears, again, this is not about to talk about the neurophysiology of pain, but the chronification of pain is a terrible problem, and it becomes a problem itself. So it's necessary that doctors recognize pain as a critical problem to be resolved as soon as any patient starts reporting pain, and use the best available treatment to its specific clinical situation. And in the case of women, of course, much that. So just to summarize the negative impact that endometriosis has on women, the diverse and interrelated symptoms, the uncertain course of the disease, the complexities with clinical management, is a complex situation that influence all aspects of woman's life, and also have influence because usually women start to have these symptoms early. Probably they are not get a diagnosis, probably unless they are 30-something, even 40, but all the symptoms probably may have had earlier. All domains of women's life are significantly affected, and just well, talking too much, trying to that's we have to individualize, we have to treat and control pain, we have to develop self-management strategies, and try to accommodate and I mean to clarify what this delay in diagnosis mean, which is an interesting, for me, recent topic in order to clarify exactly this. And this is something that we also planning to do. It's very complex because it's in this whole process of the uncertainty in clinical management. There's also some issue which it's very important. I recognize it, how important it is, but here I haven't tried to avoid talking like a medical doctor, but now I'm talking like a medical doctor. So if women want to use complementary therapies, I can understand that, but talk to your doctor. Talk to your doctor before using any other treatment. You may decide whatever is fine with you, but talk to your doctor before. So but for this, you have to be able to have developed an effective partnership with your doctor. And we know that if this is not the responsibility of the patient, this is the responsibility of the doctor. So, and again, but please don't use complementary therapies without talking to your doctors. So this is my doctor perspective here. And doctors have to develop not just clinical knowledge, which we assume in medical schools to provide our students, but also to have the capacity to create in patients, in this case, women with endometriosis, the real understanding what the disease is, the clinical uncertainties that they are going through, difficulties to really get to a diagnosis, but at the same time, treating pain, which is critical and essential in this disease. So I could keep on talking for, but I think you could have some questions or comments. So thank you for your attention.
Thank you so much for sharing, Dr. Sarria Santamera. So Anna had to go, and she wanted to send her regret that she had to leave, and so something pulled her away. So I'm gonna wrap up here. If I can I'll just share my screen really quickly. Okay, and then we can wrap up with the question and answer session. And oh, mine's a little slow. Oh, sorry. I'm not as fluid here as I'll share present. All right, there we go. I got it. So if you have any questions, you can put it in the chat, or you can open up your mic. That was really great, very informative. I really appreciate you presenting that. So if anybody has questions, we'll take that. We'll take them.
Excuse me, can I have a question?
Yes, please.
So can I ask the question? Sorry. So can it be identified or found by ultrasound of the pelvic organs?
If you can, yes. Ultrasounds are typically used. The problem with ultrasounds is that will only detect some cases of endometriosis, and even if they detect endometriosis, the gold standard is actually only accepted biopsies, because not even direct observation by a doctor is considered real diagnosis of endometriosis, because it's really very difficult through direct observation. And only even the most expert obstetrician and gynecologist could fail in identifying a lesion as being actually endometriosis or not. So this is the problem. If you start to seeing a woman with this, you may request, let's do an ultrasound. But if you don't find anything, it may be endometriosis. And if you find something, it may not be endometriosis. That's the problem. And that's the same for MRA. It's exactly the same situation. So you may find an image which is compatible, but even if it's compatible, it has to be also integrated into the clinical signs and symptoms of this woman, and of course, based on that, make the clinical decision to treat or not treat or change treatment of this woman.
Okay, thank you.
Any other questions? Okay, great. If there are no other questions, then thank you.
Can I tell you the story of the 10%?
Go ahead.
1 minute. There was a paper published like 30 years ago. And this is a classical paper that was later supposedly be the base for this 10%. But the actual base of the 10% is a second paper that was published like 10 years later that said that in the original paper, this original author indicated that the prevalence is 10%. But if you go to the first paper, you don't see at all that this first author says that the prevalence is 10%. This author said they're having a study saying that the prevalence is this, it's that. But what this author said, if this is very, very interesting, is what should be the correct study to investigate and define the prevalence of diabetes, endometriosis. So the whole chain of 10% came from a second paper that somehow make up a figure of 10%, but sitting this first paper. So, and even WHO now recognizes that the figure, recognize, accept and indicates 10%. And then the story came this 10%, because we started this project, this research, because women with endometriosis in Spain were actively requesting that the figure of endometriosis has to be 10%, because that will mean that this is a highly public health problem, because it's affecting a significant proportion of the Spanish women population. Then we started investigating, and we were not able to find 10% for a new place. So we did not find, and then we reviewed the whole literature, and we came to this problem. See, 10% was hit by this second paper, but it's not even in the first paper. Of course, there are some studies which have been published higher prevalences, but when you did this meta-analysis, pulling together papers, what you came up is with figures like similar as we did. And having said that, at the same time, I'm sure that the real prevalence of endometriosis in the society is much higher. I'm totally sure. So I'm totally sure there's no question about that. But if you say, what's the scientific evidence, accepting what scientific evidence would mean, you cannot say that it's as high as 10%.
Wow, that's a really interesting point of advocacy for gender, for women's issues, and how women's issues have to be advocated in
Yeah, they are strong advocates, I can tell you.
Yeah.
The woman with endometriosis in Spain.
Wow.
Yeah,
great.
no,
Thank you. Thank you for sharing.
Sure.
So
My pleasure.
I just want to kind of wrap up here because we're at time. So our next virtual research talk is October 6th with Torgan Isa, also from the NU School of Medicine. Oops, sorry. And then here's just a few ways to get involved. You can share your thoughts about a Gen Con event, suggest a new topic or event, provide ideas for a speaker, offer some support in terms of organization, social media, networking. Also, please feel free to email us at gencon@nu.edu.kz, and we have a mailing list as well at gencon.org. So thank you again for joining, and thank you for presenting. That was really fascinating, and hopefully we will see you all soon.
Okay.
Thank you for organizing this event. And thank you, Professor, for sharing this information.
Yeah. You're very welcome. It was my pleasure.
Have a great day.
Yeah.
Oh.
Thank you. Bye.
Bye, everybody.
Goodbye.
Bye.
Thank you so much, and bye. See you next time.
Bye. Thank you.